Okay, with that said, we can now move into our fourth and final lecture of this wonderful unit. We kind of put everything that we've been talking about here for the last couple class periods, we put it together, and we create the skeleton. Okay. So we'll be talking about joints. Okay. Bones are too rigid to bend without being damaged. Fortunately, flexible connective tissues form joints, holding bones together while still permitting, in most cases, but not always, some degree of movement. Okay. Joint also goes by the term articulation or arthrosis, which we've kind of used articulation a little bit as I've talked. Point of contact between two bones could be as simple as the connection between the patella sitting on top of the femur, between the tip of your pinky and the middle part of your pinky. Could also be between bone and cartilage, or even between our bones and our face and our teeth, so the maxilla and the mandible. Okay. Now, what we'll spend most of our time talking about in this lecture is the type of joint where you've got two bones meeting one another. Okay. There's kind of two different ways to classify joints. First by structure and then by function. When we talk about structure, there's two kind of pieces of criteria that determine the classification: the presence or absence of what we call synovial cavity, and then the type of connective tissue that binds the bones together. Okay. Well, fibrous and cartilaginous joints, based on their name, should be pretty indicative that we're not talking about one that has a synovial cavity, because what we literally have listed here is the third category are those that are synovial joints. Okay. Fibrous joints and cartilaginous, as you can see right away, I list and describe them as having no synovial cavity. In the case of fibrous joints, the bones are going to be held together by dense, irregular connective tissue, rich in collagen. Okay, so it's a really strong type of joint. And examples include the sutures of the skull, which we've talked about, what we call syndesmoses, which we haven't talked about, but we'll describe them on the next page. And then what we just talked about, like with the connection between the tibia and the fibula, interosseous membranes. Okay, cartilaginous joints, also no synovial cavity, and it's as easy as named. Thing you'll see this semester: cartilaginous joints are held together by cartilage. As straightforward as that goes. It includes synchondroses and symphyses. For example, like the pubic symphysis that we talked about, that little piece of cartilage between the hip bones. We'll see those on the next page. Most of what we'll spend in this lecture, and most of what you probably think about when you talk about a joint, would fall into this final category. Synovial joints have a synovial cavity present between the bones, and the bones are going to be held together by dense irregular connective tissue of what's called an articular capsule. These are the type of joints that are often accompanied by accessory ligaments. So it would be like your knee, your hip, your elbow, your shoulder that we've been talking about. It's just any freely movable joint, okay? Any that allows decent amount of motion. Okay. And speaking of motion, that's basically the piece of criteria that we use when we classify joints based on their function, how much movement or motion they permit. Okay. Synarthrosis are the type of joints that are immovable and include sutures in the skull and what we call gomphoses. Amphiarthrosis joints allow for a little bit of motion, not very much. Includes a couple of those things that we've mentioned before in interosseous membranes, pubic symphyses. And then diarthrosis, that would be what these synovial joints are, just any freely movable joints, hip, knee, ankle, shoulder, etc. Okay, so like I said, we'll spend most of our time talking about synovial joints, and the diarthroses that are freely movable. But I do want to just spend one more slide talking about the other two. So we're going to talk on this slide about synarthrosis and amphiarthrosis. Once again, synarthrosis joints are immovable, amphi are slightly movable. So the kind of joints that we really don't think of most often when we talk about joints. And then amphiarthroses here at the bottom. I'll go and let you fill in all the blanks, and then we'll just go ahead and talk about everything. Okay, let's start with the two synarthrosis joints, which once again are immovable, include the sutures that we've talked about, and then a new joint to us, gomphosis. Okay, sutures are immovable or only slightly movable, and so that kind of falls in the face of what I've been saying, but they are fibrous joints that closely bind the bones of the skull together. In infants and children, remember our skull as newborn babies is not completely solidified. We have those soft spots. Well, as the skull grows during childhood, the sutures need to be a little bit flexible. So there is a little bit of slight movability. That's a word, I guess. I'll make it up if it's not. So they would be classified as amphiarthrosis joints. But in adults, when your head has solidified, the sutures become immovable. So they're classified as a synarthrosis. Okay? We only have sutures present between the joints of, and joints between the bones of our skulls, like between the frontal bone and the parietal bones, and so on and so forth. We talked about like the sagittal suture and squamous suture, etc. There's actually 3 types of sutures depending upon like how the two bones connect. Serrate suture, I would say, probably are the strongest. It's like a jigsaw puzzle putting them together, so there's a lot of point of contact between them. Lap sutures, there's like a beveled edge where they kind of overlap one another, and then planars kind of butt up one another. Not that I'm asking you to know that, but I just kind of thought that was interesting. Shown over here on the right is what we call a gomphosis. Okay, fibrous joint between the attachment of the tooth to its socket. Okay, the easiest way I remember this, think about like around your teeth, you have your gums, right? Well, the word gomphosis kind of sounds right at the beginning like gums. Okay, so if that helps you, that's probably a pretty good way to remember it. Okay. In this joint, the tooth is held in place by what we call a periodontal ligament. If I kind of zoom in at the picture, this periodontal ligament is this little white band right here that connects the bone to the actual root of your tooth. Okay, this is just collagen fibers that really give a good, at least in a healthy situation, connection that permits no movement. Unfortunately, as kids, I shouldn't say unfortunately, it's normal. That becomes loose and that pushes the tooth out as we lose our teeth, and then the new ones, permanent teeth, come in. We'll talk more about teeth when we get into digestion, because that's what your teeth do. They help us with digestion. So that'll be much later in the semester, and we'll learn much more about periodontal ligaments and everything else. Okay. All right, now we can move into amphiarthrosis joints. First, I want to talk about is a syndesmosis. Fibrous joint, which there's a greater distance between the articular surfaces and more dense irregular connective tissue than what we see in a suture. This connective tissue is typically arranged in a bundle or ligament, allowing the joint to permit slight movement. So that's why it's amphi, okay, not synarthrosis. Example would be the distal tibiofibular joint, where the two tib and fib bones meet. There's a ligament right there called the anterior tibiofibular ligament that helps hold those bones to one another. Okay, so that right there would be an example of a syndesmosis. Right above that in that same picture, actually we've got animated in a cadaver version, we see one of those interosseous membranes that we've mentioned, which we also have in places like our forearms. long sheet of connective tissue that just holds two long bones to one another. Okay. So an interosseous membrane is a substantial sheet of dense irregular connective tissue, binds neighboring long bones together while permitting slight movement. Okay. The last two are both cartilaginous joints. Synchondrosis is a cartilaginous joint. A symphysis is a cartilaginous joint. So we're going to involve cartilage. The key difference between the two is what type of cartilage. And this is something I would definitely highlight if I were you. Synchondrosis involves the bones being bound together by hyaline cartilage. Whereas in the case of a symphysis, they're joined by a broad flat disc of fibrocartilage. So synchondrosis, hyaline, symphysis, fibro. Okay. Examples of synchondrosis joints are those that we talked about the other day, where your ribs connect to your sternum by way of what we call costal cartilage. All this white material you see here in this picture, zoom in on it here, is going to show us synchondrosis. Okay. Symphysis joints once again involve fibrocartilage. Examples include the joints between two vertebrae where we have those intervertebral discs, as we show here, but also we can see in this picture what we call the pubic symphysis, which we learned just earlier today in our previous lecture. As far as the pictures on this page, don't worry about any of them, just the definitions and information is plenty to worry about. Pictures on your page are probably pretty small and hard to tell, but that's okay, it's not important. Okay, so like I said, what we'll spend most of our time, and that starts now and for the rest of the lecture, talking about the synovial joints. Synovial joints, which are the diarthroses joints, meaning that they allow free movement, and are the more complicated joints involving several accessory structures in many cases. All right, we'll start at the top, work our way down, going through everything. Synovial joints have a unique characteristic not found in other joints, and this unique characteristic is the presence of what we call a synovial or joint cavity between the articulating bones. Function of the synovial cavity is to allow free motion to occur, so that's why we classify them as being diarthroses. Okay. First structure I want to talk about associated with synovial joints is something we've actually already talked about. We think back to our very first lecture of this unit. We talked about the structure of long bones. We found that on the end of every long bone is a little thin layer of cartilage called articular cartilage. It's a thin layer of hyaline cartilage, and it protects the bones, allowing for a slip and slide motion to occur. Talked about how, and unfortunately, as we get older, a lot of times that wears out, which can lead to arthritis. And we can see it here in our kind of general frontal section. We don't even really care what the bones are, what the joint is, but we can see it kind of in the, I don't know, grayish bluish shade. And you can also see it here. This is from a cadaver, pretty kind of cool to see. Sagittal section elbow joint, where we can see the three bones. Here's the humerus, the ulna, and the radius. You can see that kind of bright white at the end of each of those bones is that articular cartilage. Okay. Let's talk about the cavity. The articular or joint cavity is the space between each bone surface containing a slippery lubricant called synovial fluid. This synovial fluid is, I always think of it, if you've ever seen The Wizard of Oz, which is a little old movie, but the Tin Man gets frozen because he doesn't have any oil. Well, then when they lube him up, they put the oil in his joints, he's able to move. It's kind of like our oil, and so we're kind of like Tin Man in that way. So it reduces friction by lubricating the joint. It also absorbs shock so that the joints aren't getting damaged as we move them. Supplies oxygen and nutrients too, and removes carbon dioxide and metabolic waste from the articular cartilage. And it also contains phagocytic cells that remove microbes and debris that result from normal wear and tear in joint. Okay. The popping noise that you hear, like when you crack your knuckles, okay, it is due to the result from gases forming bubbles in that articular cavity. It takes time for gases to reaccumulate, which is why you usually cannot immediately pop that joint again. And so it's not like the bones cracking or anything like that. It's just like a gas bubble popping inside of those different joints. It's kind of cool. If you ever wondered where that noise comes from, now you know. And now that fluid is found inside of the cavity, and the cavity is created by what we call the articular or joint capsule. This is a sleeve-like connective tissue enclosing the articular cavity and retaining the synovial fluid. There's two parts to it: an outer fibrous membrane, a layer of dense irregular connective tissue, mostly made up of collagen, continuous with the periosteum of the adjoining bone. Remember, the periosteum is the thin membrane on the outside of bones. Okay, the fibrous membrane of that capsule connects to it, and that's how we kind of connect the two bones. Okay, the inner part of the capsule is what we call the synovial membrane. Okay, the synovial membrane is made up of areolar connective tissue and contains elastic fibers. And really important about it, and hence the name, it's what secretes the synovial fluid. Okay. Now, at many synovial joints, the synovial membrane also includes accumulation of adipose tissue called articular fat pads. And overall, what the capsule does, aside from kind of putting the bones together, provides great tensile strength and helps prevent bones from dislocating. A lot of that comes from the fibrous capsule. You can see it very nicely here in our picture. On the picture of the cadaver, it's kind of hard to see the capsule. You can kind of see where they've labeled it a little bit better here on the front side of the elbow. What you won't be able to see are the two layers like you can over here. They've nicely color coded it with kind of gray and then red to stand them out. What you can though see very nicely in this image though is the cavity where the synovial fluid would be if this was a living individual. Obviously, we wouldn't want to do that to their elbow if they were living, but that would be what we show here in yellow, the cavity where the synovial fluid is. As far as this picture goes, I do want you to know it. The things that are capitalized for you are what I want you to know. So just put a star or highlight those. Okay, like I said, in many of our synovial joints, we have accessory structures. Okay, many of them will have what we call ligaments. We've talked about ligaments since the very first lecture of this unit. We learned a ligament is a sheet of collagenous connective tissue attaching one bone to another. And I told you at that time, think like bone to bone, because that's what they connect. Okay. There's two types of ligaments, extracapsular and intracapsular. And we've seen those prefixes before. Extra means outside, whereas intra means within. So that's where you find these. Extracapsular are outside the articular capsule. Examples include the LCL and the MCL of the knee that we'll talk about later in this lecture. We already kind of have referenced the MCL a little bit in our last lecture. The intracapsular ligaments occur within the capsule, but they're actually excluded from the cavity by folds of the synovial membrane. Examples of those would be the ACL and the PCL of your knee. And those four ligaments, LCL, MCL, ACL, and PCL, are kind of the four major knee ligaments. We'll talk a lot about those later in the lecture. Similar to ligaments are tendons, sheets of collagenous connective tissue, and in the case of tendons, attached muscle to a bone. And since we're talking about synovial joints providing motion, okay, we're talking about joints that need to move. And how do joints move? Muscle contraction. So we're going to see a lot of muscle and tendon interaction with joints. And bursas are fibrous sacs that fill up with synovial fluid, located in areas where a tendon are going to pass over a bone or between bone and skin. And this structure helps tendons slide more easily over joints. We can actually see one labeled right here in our image. Basically, it's just like a synovial fluid sac. And if you've ever heard the term bursitis, this is where that can become inflamed. Let me show you an example of elbow bursitis. I'll Google it real quick for you. actually had this happen to me when I was in high school, but it kind of went away over time. But see that big knob on the back of their elbow? That's not that bony bump. That's actually bursa that's kind of ballooned up. Sometimes they can, be pretty gnarly looking. This one's pretty nasty looking. Someone's pretty gross as well. Typically not a big deal. They might have to drain the fluid. Like I said, I had it happen to me in high school. I was playing basketball and I kind of got tripped and fell on the floor. My elbow hit and did not feel very well, but not a big deal. It went away without too much trouble. That's what a bursa is. Now, similar to those are tendon sheaths. These are tube-like bursae that wrap around certain tendons experiencing considerable friction. We find them at the wrist and ankle where we have a whole lot of tendons coming together in a confined space. So in our next unit, when we talk about muscles in greater detail, and we'll talk about muscles of the forearm and then the wrist and ankle, we'll see some tendon sheaths. Menisci is the plural form of the word meniscus, which I'm sure you've probably heard that term. Another term for a meniscus is an articular disc, but these are pads of fibrocartilage lying between the articular surfaces of bones and are attached to the fibrous capsule. And the function of them is to allow two bones of different shapes to fit together more tightly. They also help to maintain stability of the joint and direct the flow of synovial fluids to areas of greatest friction. Okay. Anybody know where you have your meniscus, menisci? They'll be in your knee. Okay, you have them in other places, but that's where they're most commonly known. In fact, those two bones that we just talked about, the tibia and the femur, have those condyles that interact with one another, but to prevent those two really strong bones from just pounding on one another, you have a meniscus on each side. Actually, there's a medial and a lateral meniscus. We'll see those later in the lecture, but those are just basically shock absorbing agents to keep those two bones from really hammering on one another. And then in ball and socket joints, we have what is called a labrum. Okay, labrum is a fibrocartilaginous lip extending from the edge of a joint socket. Okay? Examples of places where we have ball and socket joints would be our shoulder and our hips. Okay? So if you've ever heard of the labrum, more than likely you probably heard about it with the shoulder. Fairly commonly injured. If somebody tears cartilage in their shoulder, it's probably a labral tear. Function of them is to deepen the joint socket, increase the area of contact between the socket and the ball, like that. Okay. Now, the other day, I believe somebody asked me about being double jointed. If it wasn't this class, it was one of my other classes. But people that are double jointed don't really have extra joints. They don't have extra articular capsules or anything like that. People that are double jointed have greater flexibility in their articular capsules and those ligaments, which is going to increase their range of motion. So that's fantastic for them. They can show off and bend their knee backwards or whatever. Unfortunately, these flexible joints are less structurally stable and are more easily dislocated. So they have that unfortunate side effect. Okay. Last thing I want to talk about is just like nerve and blood supply to joints. The nerves that supply a joint are the same as those that supply skeletal muscles that move that joint. Synovial cavity will contain many nerve endings distributed to the articular capsule and associated ligaments, conveying information about things like pain as well as degree of movement and stretch of the joints. And then many of the components of a synovial joint are avascular. Vascular means that they have blood flow. Well, if you attach the letter A to the beginning of a word, it means like the opposite, or not. So avascular means not vascularized. Okay, so there aren't blood vessels flowing through a lot of these structures, but there are arteries in the vicinity sending out numerous branches that penetrate ligaments in the articular capsule, delivering oxygen, nutrients, and there's veins nearby as well that remove carbon dioxide and waste from joints.
I have a kind of off-topic question. So in our lab, it was showing us veins versus arteries, and it showed all the arteries on the right side and all the veins on the left side.
That wouldn't be how it is.
It's just veins and arteries.
Yeah, it was just probably shown that way to illustrate it. You're gonna have veins and arteries on both sides.
Okay.
Stuff like that.
So then, like all the arteries that it was showing going through your fingers are all in all of your fingers.
Mm-hmm. What you find a lot of times is you might have like arteries on more of one side and veins on the other, but in between them, you're not going to be able to see these without a microscope. Are the blood vessels called capillaries, which are where like nutrients are able to leave the blood, wastes are able to enter the blood. And they're, like I said, microscopic. We'll talk more about vascularization and arteries, veins, capillaries in a few weeks, probably more like a month and a half. Okay, now since we have that special feature of synovial joints allowing for motion, we'll talk about what types of motion joints can do. Okay, now this is an important thing to understand, especially for I was like physical therapists. One of their most important jobs as a physical therapist is to help a person after they've been injured or after they've had surgery retain and regain the ability to move a joint. You know, when you have surgery, when you have an injury, a lot of times the joint kind of freezes or a range of motion is reduced, and so doing different activities, you know, going through physical therapy helps regain these different motions, at least, you know, to a certain degree. Maybe not all perfect as like before surgery, before injury, but somewhere in that general area. So physical therapists definitely are going to want to know the different types of motion a certain joint can perform. Now, these precise terms may indicate the form of motion, the direction the movement occurs, or the relationship of one body part to another during movement. We categorize the four main synovial joint movements as following. Okay, the first is the simplest. We call these gliding motions, just a simple movement in which the relatively flat bone surface is going to move back and forth and from side to side with respect to one another. So they're just going forward, backwards, slipping and sliding over one another, and back and forth, side to side, where there's no significant alteration of the angle between the joints or between the bones, excuse me. Okay, so since there's not much of an angle change, there's very limited range of motion, and it's all because of the structural makeup of the articular capsule and associated ligaments and bones. Okay, examples of joints that perform gliding motions include the intercarpal and intertarsal joints. Okay, well, what would your intercarpal joints be?
Like your wrist to your hand.
You're close. So a lot of times I have students think this is your wrist joint. Well, your wrist, think about what your wrist can do. You can do a lot of motion with your wrist. What does the prefix inter mean? Between, right? Well, when you do those wrist motions, those bones in the wrist, like the scaphoid and lunate, when they touch each other, they slip and slide over one another. So an intercarpal joint is the joint inside of the wrist between those 8 different carpal bones. And same thing for intertarsal, except now we'll be talking about in the ankle. Okay. Now, when we think about movement, the last 3 categories are going to be what we really truly think about. Angular movements, named angular because we're going to change the angle, either increase or decrease it. So angular, angle, pretty straightforward, I would think. Includes a whole host of different motions: flexion, extension, lateral flexion, hyperextension, abduction, adduction, circumduction. Okay, we'll see those here in the next couple slides. Rotational movements involve a bone revolving around its longitudinal axis, so it's rotating or revolving, which can be either medial or internal, or as it's also known, lateral external. And then examples of that would be like when you shake your head side to side, is, you know, when you don't know something, you say no. And then special movements occur only at certain joints, and there's several of those that we'll see here in the next couple slides. All right, we'll start by talking about 4 that kind of all go together, especially the first 3. Some very common joint movements that occur at several different major joints. Flexion, extension are the opposite of one another, okay? Flexion is a movement that decreases a joint angle, usually occurs in the sagittal plane. And when we say decreasing a joint angle, think of like where you start is always anatomical position, okay, where like your elbow is straight, okay? Well, you know, if you think like if you're doing with a protractor measuring angles, okay, you decrease it by, you know, pulling the angle from like 180 or close to it, where the like the elbow straight to now bent, okay, maybe now it's at like 30 degrees, okay? So flexion decreases the joint angle, whereas extension straightens the joint and generally returns it to the zero position or anatomical position. Both flexion and extension motions occur in what we call the sagittal plane. So in other words, the motion is like towards the front or back, okay? Now, flexion extension take place in a lot of places, not just the elbow, as you can see. We can also see a lady here lifting her leg up. She's performing hip flexion. Her knees also going through flexion. Okay, we can see the wrist going through flexion. Okay, when the wrist is straight, it's going through extension. When the knee's straight, it's going through extension. When you're standing straight up and down, your hip is in extension. Okay. There's also what we call hyperextension that occurs if a joint can be forced to extend beyond the zero position. So it goes back behind it. Okay, we don't have this ability at all joints. Okay, and unfortunately, this is a typo. Hypertension is not what that should say. It should say hyperextension. Hypertension is high blood pressure. So obviously not what we're talking about here. Goof up by the publishers that made this picture. But hyperextension occurs, like I said, only at certain joints, like your knee, your elbow. We really don't want to see that. If you're double jointed, you might be able to do a little bit, but only a couple degrees of hyperextension. If like you hyperextend your knee too much, you could tear that ACL. So wrist is a good example where you can do that very nicely. And then over on the right side, it's not labeled, so you might want to label it in or just draw an arrow to it, is what we call lateral flexion. This occurs only in two places, and it's always with the spine. It's either with the head or the trunk being tilted to the left or right of the midline, usually occurring in the frontal plane. We have what we can perform cervical lateral flexion, which like when you turn your head sideways, and then when you do what she's doing, she's performing lumbar lateral flexion. Couple circular type motions or rotational motions include ab and adduction, and then circumduction. First two, ab and adduction, are the opposite of one another, just like flexion extension were. Abduction is the movement of a body part in the frontal plane away from the midline. Remember, the midline is that imaginary line going down the center of the body. Okay, if you're moving farther away from it, like what she's doing here, where we're pulling the arm up away from the anatomical position, that would be abduction. She's doing it in two places, with her arms and then down here with her legs. Okay, it's not labeled, so you might want to label this picture. Okay. What joints are showing this motion, or where is this motion occurring? In the upper body, it would be the shoulder. What about the lower body? The hip. Good. Okay. Now, abduction is this picture. This would be adduction. Okay. It begins with the word add. If you think of it this way, it's just kind of easy. You're adding toward the midline. You're bringing things towards the midline. You're bringing it close to that imaginary line. Okay. Same thing, shoulder and hip adduction shown in this image. And then circumduction, what's shown over here on the right, occurs when one end of an appendage remains fairly stationary while the other makes a circular motion. Okay. Same joint we've just talked about doing this would be your shoulder. All right, rotation, movement in which the bone spins on its longitudinal axis. If it's toward the midline, if we're going towards the center of the body, we call it medial or internal. If it's towards the outside, we call it lateral or external. Okay, you can see they're labeled as such. Okay, so you don't need to draw anything in. Make sure you can tell the difference. Okay, medial, lateral, lateral. What joints are moving in this case?
The elbow and the.
No, it's not. It's the shoulder and the hip. Okay, your elbow is only able to do flexion extension. Okay, it's the shoulder that's working, and it's the hip. So kind of misleading by the look of it. Okay, right and left rotation, hopefully pretty common sense. Okay, another spinal type motion occur when the chest or the head tilt to the right or the left. Pretty straightforward there. And we can perform cervical when you shake your head no, or lumbar when you twist your whole torso. Now these next two are rotational, but they're special movements. We can only do these two motions in our forearms. Okay, what we call supination and pronation. And this involves that motion between the radius and the ulna. When we're in anatomical position, are we supinated or are we pronated? Supinated, good. Okay, because the palms are facing anteriorly. Okay, easy way to remember this is how I was taught. Okay, if you make a bowl of soup and you want to carry it, how would you hold your hands? Supinated. Okay, if you are a pro basketball player, you dribble a basketball with your palms facing downward, you are in pronation. Hopefully pretty straightforward, easy ways to remember those. Now the next two are associated with the wrists, ulnar flexion and radial flexion. Okay, this one would be radial on the left. This one would be ulnar. Okay, tilting the hand towards the little finger. So this motion's occurring at the wrist. Then towards the big finger, your thumb would be radial. Actually, I learned those as wrist add and wrist abduction, but it's fine to know that way because that's what it's in the textbook. Okay, some more special movements occurring down at the ankle. We have two different forms of flexion at the ankle. And then inversion, eversion refers to what you can do with like the bottom of your foot. Okay. Plantar flexion and dorsiflexion are the opposite of one another. There is no such thing as extension at the ankle. Okay. Dorsiflexion is where you bring the toes off the floor. So like if you rock back onto your heels. Okay. Plantar flexion is like what you do when you go to a tiptoe. Okay. You point your toes down, point for plantar. I've always thought of it when you drive, you plant your foot on the gas by going into plantar flexion. Okay. Inversion, the bottom of your foot, the sole tips medial or in, versus eversion, it points out or laterally. Okay. Between the two, which one's more easy to accomplish?
Inversion.
Inversion. Okay, just the structure of the ankle, and you point your bottom of your foot in a lot easier than outward. Fortunately, an inversion ankle sprain is the most common injury in sports because of that reason. Okay, we'll finish this slide real quick and then we'll call it. Okay, elevation, depression, hopefully pretty straightforward. Elevation is going up, raising a body part vertically in the frontal plane. So you can see him bringing his shoulders like he's shrugging, versus going down is depression on the right. We can do this at the shoulders, obviously. Another great place that we can do it, I'm doing it right now as I talk, using my jaw, my mandible, the TMJ, elevation, depression. Protraction, retraction, a couple more opposites of one another. Protraction is the image on the left. Retraction is the one on the right. Protraction is anterior movement, so going forward. Retract, you're going backwards. Move posterior movement. And we can also do that with our jaw. It's not quite as pronounced as what you can do with the shoulder, upper torso. And then one of the best things that we can do is perform opposition. Okay, it is a movement of the thumb at the carpometacarpal joint, so right where the bottom or the first metacarpal and your carpals meet. Okay, this is what enables us to take our thumb and move it over to every other finger. Okay, and touch those fingers. If you've ever heard the term opposable thumbs, okay, humans have that, and so do other ape animals like chimpanzees. Okay, it enables us to do all sorts of wonderful things, like manipulate the pen or pencil that you've been using to take notes. And I mentioned earlier, I broke my wrist and had to spend 6 months in a cast. My thumb was put in place. I couldn't use it, so I got really good at doing stuff with like my two fingers, ring and or not my ring, but my index and my middle finger. Not very easy. Try putting on a pair of pants or buttoning up a shirt without using your thumbs. You'll really grow to appreciate them. What's cool is actually if somebody has like a thumb that's damaged or they get it chopped off, sometimes they'll take your big toe and move it up there so you can continue to do this. Okay, so make sure you know those definitions as well as the pictures to go along with them. We'll start with types of synovial joints on Tuesday when we pick back up with things.